Great. Thank you, Lang. Our next speaker is Dr. Majed Constantine from Ohio State University. Sorry, let me get this set up so we can see. Majed is a professor and division director of maternal fetal medicine at Ohio State and is leading several large efforts there, including their MFMU site and the TRP component. So, Majed, I'll turn the floor to you, where you will be talking about their work with the TRRP on developing extracellular vesicle-based research platforms.
Thanks, Sarah. Good morning, everyone. It's good to be here again for the third day. It's been a great meeting so far. And thanks for putting it all together. Really great discussion. Some of you may have seen some of these slides in prior meeting, but this is just an update on where we are in this project, which was funded 6-7 months ago or so as a TRRP to add to the MPRINT resources. And it's a collaboration between Ohio State and the University of Texas Medical Branch in Galveston. These are my conflict of interest and support from grant support and industry. I don't need to remind the audience, but pregnant and lactating women have been excluded for the vast majority of clinical drugs and development and therapeutics trials for multiple reasons, and the barriers for it stem at multiple levels, and I think we touched on a lot of them over the past few days and before, including from regulatory bodies due to ethical concerns and lack of enough data from pharmaceutical companies due to fear of litigations and smaller market shares, among other things, from investigators outside this room, probably because of the concern of logistics and operations and how to enroll pregnant women, as well as the some point the lack of really good, valid and innovative biomarkers to kind of assess the safety of therapeutics and the response of placenta or maternal responses to these medications in a way that could inform the safety and efficacy of drugs. On the other hand, what we call placental-mediated adverse pregnancy outcomes, which is a combination of multiple adverse outcomes, including preeclampsia, preterm birth, fetal growth restriction, fetal demise, abruption, and to a certain degree, gestational diabetes, have been increasing in frequency in the US, and almost 1 out of 3 pregnancies are complicated by one of these adverse outcomes. And one of the reasons for this increase is the kind of parallel increase in comorbidities in pregnant people, including the increased rate in obesity, with corresponding high rate of hypertension, diabetes, cardiac disease, renal disease, and others. And these adverse outcomes pose significant concerns because they lead to really high rate of maternal morbidities and mortalities, as well as neonatal morbidities and mortalities, and they put a significant economic burden on the healthcare systems. Plus, there's significant disparities both on the racial ethnic side as well as geographic urban rural side in the frequency as well as severity of these complications, particularly hypertensive disorders. And despite all of them, there's really limited preventive strategies for many of these, including preeclampsia, growth restriction, and to a large degree preterm birth as well. Specifically for preeclampsia and hypertensive, preeclampsia affects around 5 to 10% of pregnancies. Hypertensive disorders in general, including both preeclampsia and gestational hypertension, affect up to 15, a little bit more % of pregnancies in the US. And preeclampsia by itself poses really significant healthcare burden, with some estimates suggesting that a little bit more than $2 billion in estimated healthcare costs within the first year after birth from preeclampsia for both the mom and the neonate. There's limited really interventions that have been used to prevent preeclampsia, and there's none to treat preeclampsia. with aspirin being the only drug that's been approved to reduce the risk of developing these hypertensive disorders. However, there's significant controversy regarding the dose of aspirin to be used, as well as the its benefit in different population, and then when to start it. And overall, there's, like I mentioned, there's a lot of data looking at aspirin and prevention of hypertensive disorders, and just gonna go through some of these studies, and there'll be at least close to 50 randomized trials to different degrees being conducted over the past 3-4 decades, and many meta-analyses, including this one that is showed that aspirin has been associated with reduction in risk of preeclampsia, preterm preeclampsia, SGA, and other neonatal morbidities, would really can appropriate number needed to treat, similar to other interventions that we use in pregnancy. And when the authors, some of the investigators, drilled down, the suggestion was that aspirin, to be really effective, needs to be started before 16 weeks of gestation and at a dose that is higher than 100 milligram. And however, this is not clear-cut, as other meta-analyses, including this individual patient data meta-analysis published in AJOG 2017, showed that even if aspirin was started after 16 weeks, there's still significant benefit in starting it. And there's other reports as well saying that potential benefit when you're starting it early was from smaller studies. So it's all over the place. But it's particularly from the analysis that these authors done showed there's really no significant difference whether aspirin is started before or 16 weeks. And actually, ACOG currently still recommend aspirin to be used all the way up to 28 weeks, which sometimes is funny because you can develop preeclampsia at 28 weeks. So, but irrespective, in addition to the dose, there's also significant discrepancies, as some studies showing benefit with doses that is like in 75 milligram and 80 milligrams and 150 milligrams. And the reason why there's such variety, because studies across over the past 3-4 decades use really different doses. So earlier studies used 60 milligrams. The currently available formulation in the US is 81 milligram. Studies in the UK and Australia use 150 milligrams. So you could tell why there's really such variation. And that led us to things like what's going on, like what is really the dose that needs to be done, what to use and when to use it and who to use it for. And that confusion led to also confusion in clinical practice. So in a survey that we've done a few years ago, looking at the current clinical practice in the US, surveying 100 OBGYN providers and asking them that despite the ACOG and SMFM and other professional societies guidelines to use 81 milligrams of aspirin, do you recommend 162, which is 2 pills instead of 1? And 76% of responders say yes. And they quoted different reasons for this, including findings from the ASPRI trial, which is a trial that was conducted by the in Europe, looking at 150 milligram of aspirin versus placebo in women at risk for early preeclampsia using the FMF algorithm, and showed really significant reduction in early preeclampsia. And others, they quote that they use 162 in patients who are really at high risk for preeclampsia, for if they have multiple risk factors, or if they've had really early preeclampsia before, or if they have obesity in pregnancy, without really evidence to support these. But that confusion is present. So with this into consideration, there's a lot of people starting pushing to use to actually to consider doing a randomized trial comparing the different doses, especially head-to-head comparison between 1 pill or 2 pills. And we'll get to these at the end of the studies to tell you what's happening in this one. On the other hand, there's more recently, there's been really significant development in the exosomes and push to consider exosomes as potential biomarkers for placental function. And exosomes, and I'm not an exosome expert as a disclosure, and I'm happy to take any questions. But exosomes are small nanoparticles in range 30 to 200 nanometer, and they're secreted by placenta and considered to be a snapshot of what's happening at placenta at that point in time. And they have different compositions, including lipids and proteins and RNA, and this sets of maternal exosomes and fetal placental exosomes. And there's a lot of studies that's starting to look at the utility of the exosomes as mediators or markers for preeclampsia and other pregnancy outcomes, including some work that was done by Dr. Menon, who was the co-PI on this project. In this review article, looking at the utilities of some of the microRNA in these exosomes as marker for preeclampsia, as well as some of the other proteins for marker for who are differentially expressed, if you want, between women who end up with preterm labor or PPROM versus those who have term labor. In addition to using these exosomes as kind of mediators of pregnancy complications, there are some more recent data suggesting that exosomes and the cargo specific in exosome could be used to monitor therapeutics in general. And there are some papers published from cancer therapy as well as some animal models suggesting that the cargo by itself could be used for real-time monitoring of therapies, including this really interesting paper that include 8 patients with metastatic melanoma, in which the authors really analyze the EV's cargo before, during, or after treatment with BRAF inhibitors. That's medication used for metastatic melanomas, and found that using the changes in the cargo and changes in the phenotype of these exosomes could be used to identify patients who are at risk of tumor recurrence and thus resistance to this medication, for which you may consider switching them to a different class of medication. And you may ask, like, so if you identify those who are not going to respond to the drug, like in pregnancy, we use aspirin, and aspirin is all over, people use all the time. How is it really significant? Well, there's still some side effect even with aspirin use, especially bleeding. And in this paper that looked at using angiogenic biomarkers to kind of guide discontinuation of aspirin, despite the several limitations in this paper, but at least in the group in which aspirin was discontinued early, there was reduction in the risk of bleeding in this group. So potentially they could be used, and not just for real-time monitoring of efficacy of therapeutics, but also for safety assessment, especially during pregnancy. And that led us to kind of suggest that potentially these extracellular vesicles can be used as novel biomarkers to assess response to therapeutics in pregnancies, and as well as their safety. And we were lucky enough to be to have access to the MPRINT, and then using funds from the MPRINT opportunity pool with Dr. Kara Root from Ohio State as a PI, we proposed this project and were funded, in which we enrolled people who are at risk of preeclampsia and who were receiving aspirin, whether 81 milligram or 162 milligram as part of clinical care, as well as a low-risk cohort that was not receiving aspirin. Samples were collected around 28 weeks gestation, and in a real high-risk cohort in which the rate of preeclampsia was around 29% in the control group. And the EVs were isolated using multi-step centrifugation, followed by ultracentrifugation, size exclusion, column purification, and multiple washes. And what we found that there was, between the 3 groups, the control group of aspirin and then the low dose, the 81 milligram dose and 162 milligram dose, there was really no difference in the EV size or shape or even some of the EV markers, suggesting that we need to focus more on the cargo of these exosomes. And using the combination work between a UTMB for isolation of these exosomes, as well as with Brian Sears in the biomedical informatics at Ohio State, Brian was able to analyze these data, and on average, there was 400 or so protein that were expressed in these different exosomes. Using Scribe and deep learning with prostate, he was able to identify there's some, using, and as shown this heat map, looking at the aspirin dose in general, whether it's 0 or 81, 162, versus in a group of patients who developed or did not develop preeclampsia, they identified at least 14 proteins that were differentially expressed between these different groups with a false discovery rate of 1%. However, the study is limited by the sample size in the different groups, and thus that led us to propose this project to develop a platform using these exosome profiling as a novel biomarker to monitor therapeutics, to monitor the development of placental-mediated adverse pregnancy outcomes, such as preeclampsia and response to therapeutics, for which we wanted to test preeclampsia as the child of these APOs, as well as aspirin as therapeutic agent of choice, because it's the most commonly used medication to prevent this disease. The three goals of the project include: one, to develop and validate a multi-marker panel from both maternal and fetal/placental exosome to help us monitor the placental and function in people at risk of preeclampsia, especially in response to aspirin, and characterize these maternal and fetal EV proteome profile in the second and third trimester of pregnancy, and compare them between those who develop or not develop preeclampsia, and correlate them with the aspirin dose that's used, as well as the salicylic acid concentrations in these people. And then the other aim is to compare these changes in the exosome profile in pregnancy with other biomarkers that has been associated with preeclampsia, including angiogenic biomarkers, some inflammatory biomarkers, as well as looked at their ability to be associated with other pregnancy outcome. With the whole goal is ultimately to be able to use changes in the phenotype in these biomarkers to identify patients who are at risk of preeclampsia despite aspirin, for which they may benefit from additional therapeutics or be enrolled in additional trials in the future. And I also look at the safety of in this pregnancy, for which we had put a multidisciplinary team across the two institutions, including maternal fetal medicine specialists with hypertensive disorders of pregnancy and aspirin expertise, Kara Rood and myself, as well as pharmacology, Mitch Phelps, proteomics and biomedical informatics, both Brian Searle and Damien Wilburn at Ohio State, and the team at UTMB with the exosome biology and pharmacology expertise, including Ram Menon, who's the co-PI, as well as Anna, Jenna, and Awanit, and others. And the study design will be a prospective observational cohort of at least 1,000 people at risk for hypertensive disorders who are receiving aspirin, both 81 and 162, which could be part of clinical care at Ohio State, or if people are participating in another trial of aspirin, with the goal ultimately to use samples from 60 people, at least 60 people who developed or not developed preeclampsia on each dose of aspirin, which will give us enough power to detect at least 5-fold changes in these markers with 80% power, or 10-fold changes with 99% power. The primary outcome, as I mentioned, is the development of this multi-marker proteomic panel, and secondary outcomes, including some of the clinical outcomes we mentioned, preeclampsia and preterm birth, growth restriction, as well as concentration of the angiogenic biomarkers, or commonly thought to be associated with preeclampsia, and some inflammatory biomarkers as well. And the patients will be screened before 16 weeks, as right now our practice is to start patients on aspirin before 16 weeks. And if they were found to be eligible, they'll be enrolled, with the first biospecimen collection visit happening before 16 weeks, in which blood will be collected and stored for EV isolation, as well as getting baseline angiogenic and inflammatory biomarkers. And patients will undergo other biospecimen visits throughout their pregnancy, timed closer to their clinical visits, including one around 20 to 28 weeks, in which blood will also be collected for EV, as well biomarkers and the salicylic acid concentrations. and another visit later on in the third trimester, doing the same thing. And at the time of admission for labor and delivery, where blood will be collected, as well as placenta and fetal membranes, and ultimately clinical outcomes will be abstracted and entered in the chart. And despite the fact there are multiple ways to isolate these EVs, the team and UTMB has decided that the best approach for us is to use ultracentrifugation, in which the EVs will be isolated from plasma using multiple centrifugation, followed by ultracentrifugation, density gradient, and column purification. And the samples will be enriched using PLAB plus as markers for fetal/membrane exosomes. The content, the profile of the content will be analyzed using TWAS mass spectrometry, and process and analyze using ingenuity pathway analysis, using independent acquisition or data independent acquisition mass spectrometry by Brian and his team. And for the PK, the goal was not to do standardized PK samples, and this is something that Mitch Phelps and his teams been working on in order to try to do a minimal PK sampling throughout the gestation, in which blood will be collected at multiple time points during pregnancy to mimic some of the key points in the PK curve for aspirin in pregnancy, and ultimately develop a PK profile for these patients that could be correlated with the exosome proteomic cargo, as well as some other clinical outcomes. So far, over the past 8 months, we've finalized the protocol, the MOP, the case form. The study has been registered on clinical trials. Study forms, database been developed, IRB is approved, and actually study training was done 2 days ago. Was the goal to start enrollment in the next week or so. And the goal is to finish enrollment in the next 2+ years and ultimately move on to analysis and others work. With the ultimate goal, as this is being developed and as this ultimately is completed, is to use this platform or use the expertise and ability to do this work and share it with the MPRINT Hub and the other CETs, as well as make it available online for others to reproduce, as well as to use the data and work in collaboration, particularly with MFMU, as well as other networks, FNIH, industry, and other investigators, and try to collaborate with them, not just for aspirin, but potentially for many other drugs that are commonly used in pregnancy and potentially could affect placental function to a certain degree. And specifically for this one, I want to just tap into two. And right now there's a lot of buzz about aspirin. A lot of studies been conducted with aspirin, including 2 large randomized controlled trial, including this one that is funded by PCORI, in which 10,742 pregnant women at risk of hypertensive disorders will be enrolled across 11 centers in the US and randomized to 81 versus 162 milligram, with the primary outcome of hypertensive disorders of pregnancy. The study is powered to detect heterogeneity of treatment effect based on self-identified trace, based on whether the patient is using aspirin for high risk or moderate risk, based on the patient's pre-pregnancy body mass index, as well as other characteristics. And the other trial is the study that is, I don't think it's officially started, but is most likely it will start soon, the MFMU ADAPT trial, in which patients who have a prior preterm birth before 35 weeks due to ischemic placental disease, which is preeclampsia or growth restriction or abruption, or spontaneous preterm labor, will be enrolled and randomized to 81 versus 162 milligram, with the primary outcome being recurrent preterm birth. And the study is planning to enroll 2,000 patients. So partnering with these 2 studies and leveraging the both of them, hopefully, in order to kind of help support the TRRP project and ultimately share it with the networks and other community. And with this, thank you so much for listening, and happy to take any questions.
Hi, thank you so much. That was a really interesting presentation. I'm Shirley Sonoda from UC San Diego. My question is regarding toxicity. So you mentioned a little, I'm not sure what's the incidence of bleeding in your women, particularly on the 162 milligram dose, and will you be able to correlate any markers in the exosomes due to bleeding on aspirin, and could this also give you insight into bleeding with other drugs, with the exosomes in particular?
Yeah, that's a great question. And the incidence of bleeding, you know, the minor bleeding, it depends which study you look at. For example, the EAGER study, I think it was like up to 15%. But this is minor bleeding that was stopped. Really heavy bleeding, major, whether it's abruption or major postpartum hemorrhage, probably around 1 to 2%. Major bleeding in the fetus, like intracranial bleed, especially in this high-risk population, will be, you know, for the grade 3 and 4, be around like 1%, maybe less. So it's a low frequency for bleeding, and I'm not sure whether, and I don't know the answer, but I'm not sure whether the actual exosome cargo will help us identify those who are at high risk of bleeding. You know, we'll wait and see. But I think the point I was trying to make is, if we know that someone is on aspirin, but then, you know, based on what we see, we can tell that this patient is not responding to aspirin, then the point, do they need to stay on aspirin, with taking the risk that there could be some additional bleeding later on. Thank you.
Hi, really nice talk. So David Weinberg, I'm in NICHD's pregnancy and perinatology branch, and I lead the Human Placenta Project. So I'm very interested in this. You know, I noticed in your one of your later slides, it looks like you might be enriching for placental extracellular vesicles. And as you showed in, you know, early on, vesicles are released by many cells, and we know preeclampsia probably is involving not just the placenta, but it, you know, vascular endothelial cells or some other cells. So I don't know if you plan on it, but it would be great if you looked at extracellular vesicles where you didn't necessarily only look at the placental ones, you know, because there may be other markers in you know, maternal serum.
Absolutely, David, this is a great question. Actually, the pilot data was not from PLAB positive EVs, but we thought with this one, hopefully with this large sample size, we'll be able, the goal is to do both non-PLAB and PLAB, and basically maternal side and then fetal side as well. Yeah, thank you.
Yeah, great project. I've been a huge fan of extracellular vesicles for a while. What have you given any thought to sort of what the eventual regulatory path toward qualification of EVs as a biomarker could be, or approaches to that? Because, you know, you're familiar with what it takes to get something, a biomarker qualified, and with the complexities of getting to EVs.
You always have the hard questions. You know, just working with the FNIH on the qualification for the PLGF biomarker, I know how hard it is and how expensive this could be. So we actually have not particularly thought of this, to tell you the truth, but I think this would be a great opportunity as the project goes on, and we're starting enrolling these patients to kind of think for the next step, what will that look like, especially if we find something that is really interesting. And then the other thing, I mean, that would also help us, because I love aspirin, but David and other people in the audience know how aspirin is controversial, and many people, they don't think it's that magic drug. And there's a lot of potential newer therapeutics that potentially could be used to prevent preeclampsia, and for which something like this, or in combination with other biomarkers, could be used to selectively, you know, to identify these patients who are really at high risk, whether it's microRNA or PIGF or something else, that really at high risk, for which, you know, the risk-benefit ratio of enrolling them in really high-risk trials using novel medication would probably be more beneficial. But that's a great point. Thank you. Yeah, absolutely. And I think these data from the melanoma, the melanoma studies, that is really fascinating, because then you stop this drug because it's not going to work, it's going to recur, and then prevent toxicity and put them on something else.
Yeah, great project. And maybe you've already done it, but salicylate is sort of a minor activity metabolite of the active drug, which is acetylsalicylic acid. And the acetylation of prostaglandin synthase is presumably the mechanism of action for the bleeding effects and maybe for the effects on preeclampsia. I don't know. But I wondered if you have thought about measuring PGE2, and urinary PGE2 has been used as a marker of ASA effect, or looking for actual acetylated prostaglandin synthase as a better measure of drug exposure, if you will.
Yeah, thank you for the question. I think there are several pathways or mechanisms which aspirin, and we have an expert on the audience, Dr. Rupsa, who's gonna be a panelist later on, who's done a lot of work on this and tropoxin as well. And I didn't go into a lot of details. This is not part of our project, but then the MFMU project is actually looking at it, as well as looking at some of the SPMs as also another potential markers of mechanism of action for aspirin. So hopefully partnering with them, some of these patients potentially could be enrolled in both studies, and we'll have the data on both of them. But clearly this is, and also these samples will be available, will be stored, and ultimately can be run for additional analysis in the future. Yeah, absolutely. Thank you.